So today is November 3rd, 2020. We're going to be discussing the knee. So the knee is really interesting. There's obviously a lot of books talking about how to treat knee pain, both from a very general perspective as well as a very detailed perspective. It's really interesting that in a number of spiritual traditions, they link knee pain with emotional issues and spirit level issues that are affecting the heart. And what's really fascinating is the more I've delved into Master Dung acupuncture, it's interesting that a lot of the knee conditions are treated by using Master Dung points that also either primarily or secondarily have an effect on the heart, which I thought was really fascinating. This is an area of the body, along with the back and the hips, that responds extremely well to E-stim. So at some point you may want to delve into that. I mean, I didn't really start getting into E-stim until maybe about a year ago. I started researching it like about 2 years ago, and then I started using it a little bit more about a year ago. And now I would say I don't go a day without using it. You know, in the beginning, Jeffrey Yuen was, you know, he never really comes out and says, don't do this, because he's a Taoist. But what he would never really, like the way he would talk about it, he would kind of like talk around the fact that he wasn't like a big fan of it. And so for my entire career, I really just avoided using it. But I actually had somebody use it on me once, and I thought, wow, this is really interesting. This is worth a look. And it can be phenomenally healing. So this may be something that you want to explore later on. There's a number of like webinars and things like that that are available at either low cost, or some of them are for free. Okay. All right. So looking at the notes, I've given you some information about the bones, the ligaments, the muscles, the meridians. There's a couple of links to Wikipedia and other sites that can give you some visual information. I've also included an abundance of images on the ligaments, the muscles, the anatomy, the list of the muscles. I've also uploaded, along with the class notes, I've uploaded 2 things on motor points, as well as the manual muscle test for the quadriceps as a group, as well as the hamstrings as a group. So you can check that out if you haven't already. So everything starts with examination. So, you know, actually, I just want to insert something briefly that's not in your notes, but I wanted to mention this because as soon as you have a relatively orthopedic practice, word's going to get out, and you're going to have then a substantially geriatric practice. So, you know, I have to say that for me, the toughest patient for me to treat is kind of like I wouldn't say typical, but it's pretty common in the area where I treat, in just south of Baltimore City. I don't see it so much in Annapolis, but like the typical like South Baltimore, Glen Burnie patient will come in with chronic knee pain. They've had it for 10 to 15 years. They haven't really done much about it. They're about anywhere from 30 to 50 pounds overweight. They eat poorly. They're extremely emotionally reactive. They do little to take care of themselves. They get very little activity, and they're kind of stuck in complaint, and they're over 50 years old. And this for me is really the most challenging patient I can have, because their compliance is it's challenging to get people to be more compliant. You know, it's like, I feel like I'm in some secret episode of Mission Impossible. Like, your mission, should you choose to accept it, is to get this person to like convince this person like that herbs and eating better and getting some activity are actually worth it. Because most people are really just looking for a pill. And almost all of them come in with the same complaint. and they all do the same thing with their hands when they explain the situation. Well, I've finally gone to my doctor, in parentheses, after 10 years of not doing anything about this, and they said, it's bone on bone. And they all do the same thing. It's like, I swear to God, I should post this on Instagram, but it's just, it probably used to be too insulting. But like, what?
Sorry, I didn't mean to unmute.
Oh, okay, no problem. So yeah, they all do the same thing. It's bone on bone. Doctor said it's, and they frown. They wrinkle their eye. Doctor said it's bone on bone. Right? And so they've got no cartilage left. And they want me to like fix their knees, and they're 50 pounds overweight, and they won't stop eating like Twinkies and Funyuns and whatever.
They're also very popular at the Heart Failure Bridge Clinic, who is equally incapable of getting them to change any lifestyle habits.
It's really challenging. And, you know, like as I've practiced longer and longer, I've become a little bit more abrupt. And like, I just don't want to waste people's time. And, you know, I'm interested in holding the hands of people who really need some hand holding. So I'm just saying, like, there's no magic bullet. And what I found is like a combination, like, is, you know, the elemental rapport can be much more helpful. Yeah. I'm not surprised. So, you know, this is where the 5-element, you know, training that you've got, that you've received can be very helpful. It can be really challenging. So, you know, I remember Bob saying, like, don't work harder than your patients. So I don't work harder than my patients. You know, it's like, I do what I can, and I'm straight with them, and I'm clear with them, and I'm, you know, like, but I'm also compassionate, and I listen, and, you know, I try to meet them in their energetic elemental dynamic. But just be forewarned, like, what does it say? Forewarned is forearmed. So, you know, you're gonna, and to some degree, our patients are us, right? So I always have to look at myself. So what part of me, like, is kind of tough-headed, you know, and stubborn and attached to, you know, like, doing what I want to do, just cause, right? And my inner 6-year-old. So I have to look at that as well. I mean, because our patients are always a mirror of ourselves, if not necessarily in exact behavior, but they bring up our issues. And so I've long ago stopped taking it personally when someone doesn't, like, follow my guidance. All right, so I just wanted to just insert that just very briefly, and just rely on your 5-element training, and don't work harder than your patients, and just be clear. Like, don't, just be very clear and direct. Your patients will appreciate that. And I've gotten a lot of feedback regarding that when I do these, like, anonymous polls with my patients. I put out these surveys, and they can respond, and they give me feedback, and it's been really illuminating. So it all starts with examination. You know, you want to, of course, see how they're standing. You know, I've mentioned this in the notes. You know, I have them sort of, if they need to, brace their hand against the treatment table, I have them close their eyes. I bring their feet together, and with their eyes remaining closed, I have them move their feet a hip's width, what they feel like is a hip's width apart. And then I look at how they're standing. You know, are they the 2 feet sticking straight ahead? Is one off to the side? Is like 1 foot more forward than the other, or backwards? You know, what's their posture like? And I check, you know, how things are level and how all that, right? Which direction are the kneecaps facing, right? Because sometimes people have a patella that's, like, rotated off to the side. So obviously that means, you know, if it's pulling laterally, that means these lateral muscles are tight, overactive, shortened and overactive, and the interior muscles, the medial muscles, are lengthened and inhibited. So you want to make a note of that, because you might want to include motor points and trigger points, and do muscle testing and things like that. But the big thing is also to impress upon the patient. I say, okay, now look down at your posture, right? And you can get, like, these grids, or make them yourself. Like, I have this grid, this big piece of sheet of plastic, It's about 8 feet tall, and it's got this grid lines on it. When I take a picture of people like in front of the grid, you know, front ways, sideways, and from reverse, and then I show that to them and I point out, right, so they can see for themselves. I'm not just making this up. So it always starts with this, with observation, then palpation. Of course, you certainly want to check flexion, extension, rotation. You want to check Akabanis. Akabanis can be really helpful. And again, I'm a big fan of Akabanis, and don't just check them once and correct them once and then have that be the end of it. I mean, you really do need to check Akabanis for 2 or 3 visits, and maybe even, you know, for your stubborn patients. This isn't in the notes, but I'm sort of referring to the top of page 2 examinations. You know, what I learned the hard way is that, you know, it just dawned on me one day, like, oh, like maybe this isn't like a one and done test, you know, because JR actually never said just do it once, but he never said to do it more than once either. He just said, make sure you check Akabanis in the TD. But, you know, my teachers never said, now here's what you do with that. And what I've found is that people who are like slow to recover, I check them a lot, you know, or people who have like sudden flare-ups of something that we've been making good progress. So of course they go out and they overdo it and they abuse themselves, and, you know, test your patience. You know, you want to recheck Akabanis. So I'm a big fan of Akabanis. I just did Akabanis again yesterday on somebody, and it was like, I was having a hard, like I did it a couple times. This is like the 6th or 7th visit. She was doing well, and she came back. She's like, oh, you know, I overdid it this weekend. And, you know, she's 5'3", 250, knee pain, right? You know, she's also in the Army, and, you know, so she has predominantly like a desk job, but she does have to like go from building to building and climb a lot of stairs and stuff like that, because her buildings don't, you know, she just doesn't take the elevator because she's trying to lose weight. So she puts a lot of stress on her knees. So I did, and so like she had this pain that was kind of spreading up into her glutes. And so I did Akabanis again. It was like miraculous. So I'm all for Akabanis. There's a number of assessments and examinations that we will review today, some of which are listed in Leggy, starting on page 289. In Close to the Bone, 3rd edition. We'll go over the Eli's test. We'll go over the anterior and posterior drawer test. We'll go over the Apley's test, which is also delightfully called the Apley's grinding test, which I don't say in front of my patients, as well as the distraction test and the Lachman test and posterior sag sign and Thessaly and Mcmurray's. All right, so I again have listed the sinew meridians for the leg and how to evaluate them. I've also mentioned, you know, look up the type of pain that's listed in the assessment and diagnosis essay. And I've also listed a brief summary of the climatic factors. I'd like to include these in each of the notes so you have that right there in front of you for each one, so you don't have to go look up somewhere else. Again, just, you know, this is something that like you really want to memorize, like the sinew meridian evaluations, the primary meridian evaluations a little bit, but definitely the climatic factors. You really want to commit these to memory, you know, within like the first year of your practice. So you can, because what I'm doing is when I'm listening to my patients talk about what makes them better, what makes it worse, when they describe their relationship to their discomfort and pain, when they talk about, you know, situate the last time, and I always get specific, when was the last time you felt it if you're not feeling it right now? You know, as I'm listening, I'm also kind of going, okay, that maybe points to blood stagnation. Oh, that maybe points to like chi deficiency. Oh, maybe that points to potentially wind. Oh, that points to maybe this muscle group. Oh, this might, you know, refer to this primary channel movement or sinew meridian movement, right? So I'm thinking about this as I'm listening, which gets easier and easier and easier as you practice, as you get experience, but also as you commit these things to memory. Now, I'm not a huge proponent of committing everything to memory, especially because like my memory is very poor and I have to kind of do things with my hands to really get it. But there are a couple things that just like as you practice and as you commit these things to memory, you'll be able to kind of not as a conclusion, like, oh, that must be wind, or oh, that must be this, but as a hypothesis. I wonder if it's ... That's how I really want you to honor the legacy of Bob Duggan and the others that came before us that were more about inquiry and less about conclusion. And I think that you will learn more coming from an inquiry place. And I often play dumb a little bit with my patients, say, you know, it's interesting, like, you know, in the principles of this medicine, you know, pain that kind of comes and goes and moves around from place to place and is kind of unpredictable, you know, that reminds them of this natural force that they refer to as wind. Not that you've got like wind blowing around inside your knee. You know, it's not like there's this breeze blowing around or this little gale that's like blowing around inside your joint. But your symptoms, like, you know, they act as if they were wind-like. And I say, you know, it's interesting that in this medicine, that relates to this element that relates to the springtime. And then I go through the correspondences like around change. And I'm pulling out little correspondence details that relate to what they've been telling me. Like they're on the cusp of a decision, or they're having trouble planning and organizing their day, or, you know, they're feeling a lot of conflict and opposition with maybe their boss or their loved one. And so, or they're, you know, things have been changing suddenly, circumstances have been changing suddenly in their life, you know. So I go, you know, I just kind of play dumb, like, isn't it interesting, you know, that there's these correspondences? And so I try and help them connect the dots rather than saying, oh, it's this, and then it's this, and it's probably that, right? Because people hear it differently. And when they can connect the dots themselves, it's a lot better. And I do bring up emotions, especially of overwhelm, fear, power issues, abundance issues for around the back and the hip. Stability is really about the hip. And the knees, my God, really about stability, but also about stability in the face of conflict. You know, I have this one patient, it was really interesting. She discovered, I just like, well, just observe the comings and goings of your knee pain. Like, you know, just notice when you notice it, and then just when you notice it, like go, oh, okay, what's going on? Like, what's going on around me? What's going on inside me? And she noticed that every time she got into an argument with her mother, her knees ached. I mean, I've read a lot of Chinese medicine books. There's nothing in any of the books I've read that say, oh yeah, opposition with parental unit is a source of knee pain. I've never come across that. But in our Sufi tradition, like, the knees are all about the heart. Knees are all about the heart. So there you go. So that's that. So bilateral knee problems, this is top of page 3. Bilateral knee problems, if they're unrelated to acute trauma or repetitive stress, usually indicate a systemic kidney qi deficiency. And more often than not, obesity is a contributing factor of people's knee pains. So again, root branch. Knee pain may be the branch, the root might be the underlying kidney qi deficiency, compounded by an extraordinary amount of damp and weight. And, you know, I've heard like a lot of statistics thrown around, but basically, supposedly, you know, if in my experience, that's what I've put, like in all of my patients who've lost at least 10 to 20 pounds, their knee pain has dramatically reduced. So you got to help them lose weight. So how do you help them lose weight? And then you got to look at the emotional factors, and you got to look at other physical factors, including their diet and activity. But it's a double-edged sword, right? So, or what is it, like a catch-22? Like they've got so much knee pain that they can't really move around much. And since they can't move around much, they don't get much exercise, and therefore it's harder to lose weight. So that's why you've got to do it like increments, like very like incremental progress. I'm like, look, if you lose a pound every 2 weeks, right? In a year, you will have lost 26 pounds. 26 pounds will make or break probably your knee pain, as well as all of your other conditions, which are a lot of other internal conditions. Okay, so you have to keep considering things like this regarding knee pain, ankle pain, foot pain. Very important is how much body mass someone is carrying around in their torso. According to some, knee pain can generally be considered, this is from another perspective, not like a strict modern traditional communist medicine perspective. This is more of a more older perspective, that there's two basic types of knee pain. There's a hot type and a cold type. The hot type resonates a lot with the heart. The cold type resonates a lot with the kidneys. The hot type will obviously have signs and symptoms of heat, redness, inflammation, and swelling. The cold type is where there's no heat, no redness, little to no inflammation, and no swelling. And if there is swelling, it's like it will actually feel cool to the touch and really mushy. And more often than not, if there's the cold type swelling, you'll see edema in the lower leg. Yes, John.
I have a person that has recently, basically the script you gave about it's bone on bone, same thing. But what I see in this individual is below the knee, there's areas, and I wouldn't call it edema. It feels to the touch cold, but it's almost like the valves of his veins are no longer able to, control the flow of blood. And he's got these areas that almost look like, areas about this big where the veins have kind of lost some of their patency.
Yeah.
Maybe does that have a specific?
I'd really have to, if you maybe take a picture of it and text it to me. Yeah, it's really, I'm a little lost. Yeah, I don't know. I just need more information. I need to see it. Yeah. So the hot type is generally about heart chi or heart yang deficiency. Supposedly because that heart chi combined with the gu chi is not steaming the fluids enough for the water's fluids to be distributed, right? So it collects it around the knees. And then you can even maybe look at your own knees and see, like, because the hot type of knee will actually, if the swelling, because I always think swelling, edema, that's like kidney chi deficiency, lung chi deficiency, and that may be true, right? The lung chi may be insufficient to generate, along the Schenck cycle, it may not be enough to generate the kidney chi, and that may be true, but the cold type of swelling will almost always be seen with a little bit of edema in the lower leg or the ankle, and it will just seem kind of mushy, and it will not feel warm. It will feel cold. It will feel cold. Okay. But then again, you don't go just by one piece of information. You want to feel the pulses, you want to look at the tongue, and you want to consider other signs and symptoms. So you can look at Machocha and say, what are the signs and symptoms of heart chi or yang deficiency? What are the signs of kidney chi deficiency? And you look to see if any of those are present. Excuse me. All right. So in terms of the posture, so I've included a summary of Master Dong points on page 15. I believe it's page 15 of your notes. And I've just given a little bit of a statement about each one of them. Again, you can look on masterdongacupuncture.com, as well as Bible, right? 6th edition, McCann and Ross. You don't need the 6th edition. I like the fact that they kind of go into an explanation to some degree of most of the points. So it's really nice to get an understanding of like, it's not just for knee pain. I mean, this is like the kind of knee pain that it would be helpful for. And I've added just like a few notes about that, like, oh, it relates to this, relates to that. So again, it always starts with posture. I've mentioned, you know, bring the patient's feet together, have them close their eyes, spread their feet hips width apart, and then look at, you know, which directions the patella are facing. You know, are the knees bowing medially or laterally? Look for scars, obviously, you know, especially with athletes. They may have had arthroscopic surgery, which is trauma by appointment, as good as it is. They may have had like even a giant knee replacement that they've forgotten to mention, and you look down there and you see this giant scar. You look at what direction their feet are facing, whether the feet are pronating, which is called eversion, right? That's this way, in medially, or supinating or inversion, right? And so obviously that's going to put a stress or strain to some degree on the muscles of the lower leg, as well as especially the thighs and maybe even the glutes that affect the hips. I've just noticed that I put this little star in there in the middle of page 3 that for all painful conditions, I generally consider adding stomach 34 on the affected side, and I palpate that point to see if it's sensitive upon palpation. If it is, then I generally do it. For chronic conditions related to emotional states or that have been affecting one's emotions for a long period of time, I often combine gallbladder 31 with heart 8 on the affected side. And this can help facilitate the patient's ability to embrace the changes that are needed, maybe physically, maybe emotionally, maybe their mindset, you know, to let go of chronically suppressed emotions and unexpressed feelings and thoughts. And so we talk a lot about that, how to move that. You know, I can't tell you how many patients, I'm sure you've seen this as well. You're in the 9th trimester. You know, you're doing like, you're kind of like blah, 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 blah. You're kind of going along in the treatment room doing your thing. And then all of a sudden, like you glance at the patient's face and, you know, the chin starts to quiver and then the lips start to quiver and then the eyes start to well up, right? Because something is moving and they can't even explain it. And for many patients, they have no context for that experience because no one has either trained them to identify a spontaneous emotional unloading, you know, due to like the energy, like holding the energy of that in their body for so long. When it finally starts to move, they have these spontaneous emotional expressions. And you know, they've never, and so they're immediately, their mind jumps to like, I'm weak, I should have, and then they start to apologize. Oh, this isn't, then they maybe feel embarrassed. But you know, this happens, man, every day. You know, and they're like, I don't know why this is happening. I'm like, it's happening because you've been holding the emotion of this in your body for, you know, X, Y number of years, right? So you know, you gain rapport with them, you touch them if that's appropriate, and you kind of walk them through it, giving them permission and acceptance. Like, okay, this is what's, you may have thoughts going on in your mind that are telling you are critical or are tell you that you're confused, but like, just what I would just is focus on just how good it feels to like let this move, and it's okay. It doesn't mean what you think it means. And so over time, you know, people can become more at ease with expressing these emotions, and it does lighten the load a lot, especially with like knee issues and back and hip issues. So, you know, I can't tell you how many times I've put in gallbladder 31. They're like, wow, that really hurts. Holy crap. And then I put in heart 8 and they're like, oh my God, that's awful. And I'm like, okay, you know, there's the needle sensation. And I remind people not to confuse the treatment with the needle sensation. You know, that the needles may feel a certain way, but that doesn't necessarily mean anything. We know it means something, but like, I don't want to get into it right then with them. I don't want to keep them in their heads. And so, you know, and then I was like, okay, then like kind of guide them in a meditation, and then bam, and then like things break loose. So that's a nice thing to add, or whatever points work for you. I'm just giving you these, like you can do whatever, you know, whatever seems right in the moment. All right, so again, just remember that a lot of people are holding a lot. Again, you know, obesity may be, there's a lot of reasons why, you know, people carry a lot of weight. But one of them may be it just like they just need comfort, right? And that's a way of experiencing comfort. So helping them walk through that is very important. So let's start with, actually, do we need to take a break? Do you want to take like a 10-minute break till like maybe 5 of 10?
Sure.
Yeah, let's come back at 5 of 10, 9:55, and then we'll start with pain around or under the patella. So with pain around or under the patella, as well as really like most knee pains, you do want to take a certain amount of like B syndrome signs and symptoms into account, right? So really looking closely if the signs and symptoms resemble wind, cold, heat, or damp, and if so, is there a predominance of one or the other, and then treat accordingly. So sometimes somebody will come in with a diagnosis of Patellofemoral Syndrome, right? That's a common one, or patellar joint dysfunction, right? These are common diagnoses. This is very common. This is either from a weak or overly tight muscles around the kneecap, around the patella, and this is leading to the rubbing against the head of the femur, right? So the patella is on top of the femur, right? And so if the patella is shifted out of place and it's not tracking, right, that's going to increase the friction, and that's going to increase inflammation and pain. So overly tight hamstrings are very common. You may also notice potentially overly tight quadriceps, right? The rectus femoris muscle. There may be, so there's the vastus medialis, right? That goes up through like spleen 10. There's the vastus lateralis, which goes up like through the stomach 34 area. So you want to check one of those might be weak. So do the muscle test for those, for the quadriceps. And then also palpate. And then if you are having trouble finding the motor points, which I believe I've listed on the Canvas site, you can palpate those. You can also look up the trigger points and palpate those for that area, right? It should say postural imbalances, not pastoral and balances. That was, I do a lot of dictation. There's a dictation function, and sometimes I forget to double check. So it turns postural into pastoral. But pastoral counseling, of course, is quite nice. But in this case, we're talking about postural imbalances, not imbalances in your grassland or your yard. So you want to make sure you look at the hip and the ankle, right? Make sure that those postural imbalances are addressed. I will often address them simultaneously. But again, whatever is the most off, or you know, maybe they have some kind of history of injury, you know, what injury came first? If it was an injury affecting their hips, then obviously we want to start with that too. All right, so basically what you're going to experience is like a lot of anterior knee pain, right? Not so much posterior knee pain, anterior knee pain. It's going to be around the front, around the patella. They might say it feels like it's in the patella, like just under the kneecap, or maybe like somewhere like it'll feel vague. It's sort of like all over the place, but mostly in the front. And most of the discomfort is caused by going up and down the stairs. That's one of the major confirming symptoms for me. It might also be felt on just either side of the lateral and medial borders of the patella. So we can do Eli's test, which I'll show you in a moment. Obviously, you want to do your sinew and primary meridian evaluations as usual. You want to look for any elevated hip because that's very common in this kind of thing. Excuse me. And then obviously muscle tests. for the quadriceps. And you want to palpate the IT band because a lot of times the IT band is quite tight and maybe even painful. All right.
Time.
Yes.
Can I ask a question about the IT band?
Yes.
So I have been diagnosed with this a few times for the
What?
same knee and the
Patellofemoral?
Patellofemoral. Yeah. And IT bands are tight. I mean, I'm curious whether, I guess in your mind, which is the chicken and which is the egg? Is it that the IT band is so tight, it kind of pulls things out of alignment, or vice versa?
Treatment results will give you the answer to that.
Okay. So it's
all you have to know
experiment.
is that these things are going along together. And so start treating the one that's the most off.
Okay.
So what's really helpful is these tests, and then we'll talk a little bit about treatment and how to work on these like kind of all together. All right. So, and also it's on the top of page 4, extensive foot pronation. That's something that you want to look at as well. So let me see if I can share my screen here. Let me go to the website. All right, so here's the quads manual test. Can you all see that? Yes? No?
Yes.
Thank you.
We can't hear it this time. Oh.
All right, did you say you can't hear this?
We cannot hear it.
Huh, now I can't hear it.
I
That's weird.
can't hear
Oh,
it.
here we go. Okay, hang on.
In this video, we're going to go through a manual muscle test really quick for the extensors, so for the quads. So simply in sitting, if you shuffle back here so your knees are right on the edge, and I'll get you to just extend your right leg, just your right leg for me. Then I'm just going to hold just above the knee, and I'm just going to apply at the ankle a downward force. And relax. And then I would compare and contrast that. I can also do this at different ranges, so I could flex the leg a little bit more in order to look at the range of movement, or the strength in a particular range of movement. But essentially, I'm just getting a really quick idea of whether there's any gross weakness of that muscle, and then comparing that from one side to the other. In sitting, if you shuffle back here so your knees are right on the edge, and I'll get you to just extend your right leg, just your right leg for me. Then I'm just going to hold just above the knee, and I'm just going to apply at the ankle a downward force. And relax. And then I would compare and contrast that. I can also do this at different ranges, so I could flex the leg a little bit more in order to look at the range of movement, or the strength in a particular range of movement. But essentially, I'm just getting a really quick idea of whether there's any gross weakness of that muscle, and then comparing that from one side to the other.
Okay, were you able to hear that? Okay. All right, so that's a basic test of the quadriceps, and then I want to show you another test called the Eli's test.
This is going to be a video on the MRC scale to rate muscle strength.
Yikes. Okay, let's try this again.
This is going to be the Eli's test to assess for contractures in the rectus femoris. To perform this test, have your patient in prone lying position. Then flex your patient's knee maximally. Make sure to compare both sides. This test would be positive for a tight rectus femoris if your patient's hip spontaneously flexes with knee flexion. All right, this was our video on the Eli's test. If you want to check out other videos to assess for contractures of the rectus femoris, click right here, or check out our video on the Thomas test to assess for contractures in the iliopsoas right here. This was Kai for Physio Tutors.
Okay, so that's the Eli's test. Pretty simple test, right? Sometimes in the Eli's test, when you're doing that, not only will there be tightness, and you'll see the hip or buttock lift up off the table, there'll also be some like pain or discomfort. But again, one of the primary signs for me, or symptoms, is pain going up and down the stairs, okay? All right, so there's a number of different ways of treating this. And again, you know, as Teresa mentioned, with all orthopedic issues, I mean, with all physical issues, and well, frankly, with every issue, now that I think about it in my head, like whether it's asthma or migraines, or as JR used to say, migraines, it's all sort of figuring out chicken or the egg. And JR would say, if he were here, he would say that all symptoms arise from an imbalance in the spirit, because someone has either lost connection to living in accordance with the rhythms and cycles of nature, or they have lost connection with their own individual unique nature. And so the signs and symptoms are really a way of alerting us that on some level of like what we're doing and how we're doing it, or eating or moving, or that we've got some mindset that we're holding on to, or some beliefs, or way of perceiving reality that is not in alignment with our truth, right? And so this is really important, especially for the knees, again, because I've said that a lot of knee issues relate back to the heart. Now, on a physical level, and again, I don't think that there's a separation of physical level, because I do believe that when you treat somebody's physical body and you rectify the chi, you liberate the shen and you affect their mind and their spirit, right? So if somebody's in pain all the time, it's probably going to affect their mood, it's probably going to affect their mindset, it's probably going to affect the way they think and their attitudes and the way they relate to others, right? And I've seen this over and over, and I'm sure you have too as well, either in your own life or in your practice. But one of the main things that I found is very helpful for this particular is the spleen and stomach sinew meridian. Again, you don't want to just go ahead and do it. You want to test those different movements, right? So worse with sitting, you know, over a prolonged period of time, that's spleen. Standing, driving, you know, bearing weights, that's more stomach. The motor points are fantastic. So I would say, you know, definitely do the muscle tests for the quads, for the hamstrings, palpate, right? I've listed a few motor points there for you. Whoops. And then on 2B, it says Tucson lateral. Again, that's my dictation trying to say Tucson, C-U-N lateral. It turns it into Tucson.
Where is that at?
Page 4, number 2, letter B.
Oh.
So
Okay.
it should be 2, the numeral 2, and then the word sun, C-U-N. Tucson lateral from the junction of the upper and middle third between stomach
Got it.
and the superior lateral border of the patella on the stomach channel. And then you would needle 1 to 2 son deep. All right. So those are phenomenally useful motor points. And when you needle the motor point, again, you don't have to leave these in. You needle it pretty deeply. I would use at least 1.5 to 2 inch needle. You needle in. You might get the fasciculation, right? That muscle twitching. And you can leave it in for a couple minutes. You can do some very gentle lifting and thrusting just to activate the point, to tonify it. or you can use E-stim. So like you can actually connect these two different motor points, right? Two for the, vastus lateralis, and then maybe, you put in one for the vastus medialis and maybe palpate around. Maybe there's another Usher point. You could put a needle in there, and then you could connect those two together with E-stim, right? And then, 2 Hertz, as strong as it takes for them to feel the pulsing, but not so much that I would say, like, I say, okay, would you be able to fall asleep with this level of stimulation, right? So if it's like too intense, I turn it down. And then you can E-stim that for about 5 minutes. You can also get the Pointer Plus, right? And just kind of zap the needle. Very nice way of treating the motor points. The medial and lateral Shiyan is pretty good. I've described how to needle that there. It's basically like calf's nose, stomach 35, but there's also a medial equivalent of that point as well. And those are really nice points. Physical therapy is really helpful for people with this. And then there's a couple of tongue points that I thought were really nice. And you can even, when you're doing the, so going back to like treatment number 1, when you're activating the sinew meridians, you would do the Jingwell point, either bleed it if it's really intense pain, or very acute, or if it's just like moderate pain, kind of chronic, then you can just needle it, tonify it, leave it in for a little bit of time. Then you do the gathering point, right? So the gathering point for the 3 yin leg, which spleen is one of them, is around CV2, 3. And then stomach is the 3 leg yang. So that's going to be like small intestine 18, stomach 3 area. Then I go back, and you can actually like kind of surround the perimeter of the area of the pain with very shallow needles, and you include that in your sinew meridian treatment. That's very helpful. Very helpful. The channel balancing points, balance method for the elbows. Opposite knee, not so great. I don't know why, but treating the elbow for the knee seems to give me more successful results than treating the opposite knee. I don't know why. I suspect because it's more distal. The Bachman knee points are like, they're okay. Sometimes they help a little bit. Obviously Akabanis can be very helpful. If there's a lot of pain, like with the twisting and rotation, like some people come in and say, oh, like if I turn just so, sometimes it like really grabs. So I might include Daimai. If they're really dry, if they look dry, their skin looks dry, they have dry eyes, dry hair, they're also like emotionally like reactive. They're very blood deficient. You can include spleen 10 and gallbladder 34 to really nourish the ligaments and the sinews with more blood. You can also do herbs. And what I found is for this in particular, like especially like Teresa, you were talking about like a tight IT band. And if the quads or the hamstrings are super tight, or even if not super tight, if they're just tight, cupping, I just like load them up, man. Just cup, load them up. Have them lay on their side, cup the anterior and the posterior at the same time, right? Just put a, dozen and a half cups down there, right? And then let that sit for a while, and then do moving cupping along the bands of muscle that are really tight, especially the IT band, really nice. And then go back and gua sha. Gua sha is great, especially on the IT band if they can take it. Really phenomenal. So, one of the things you can do is like, let's say it's like right knee pain. You have the patient lay on their left side, if they can comfortably, put a pillow between their knees if you need. Then you could do like, then you have access to the sinew meridians. You could put that in, maybe even primary meridian treatments, right? Tonification point for stomach 41, tonification point for spleen 2, if you can get their foot angled. And then you can, like, while they're laying on their side and the needles are in, you can go back and do the cupping and then the gua sha. Really nice. You can do all that like while the needles are in. It's quite nice. And then you may even, if they're laying on their left side for right knee pain, you may even have access to, like if they're laying sort of on their side, maybe have their arm either up or under a pillow or like this, or, laying on their side like this. And then you have access to the inside of the knee. So you can do, what's it called? Shin-shi? Yeah, right? 1109. And then maybe a couple other points on the hands, the fingers. So you can have all those in like while the patient is, lying on their side and you're doing the cupping thing and the gua sha thing.
That brings up another question. If we were to do that, that's on the side with the injury. And then would we, if after doing all that to the side with the injury, would we do anything to the other side to kind of like balance things out, or only if it's also tight and tender?
I would say the latter, only if it's really tight or tender.
Okay.
Yeah.
Okay.
But that's a good question. Yeah. And then, you can apply any kind of like topical liniment or, plaster. Really helpful. Like once the needles are out, you can kind of just like massage that in for them to show them how to do it. It's a nice touch. People feel very cared for. All right. So that's dealing with pain at or under or around the patella. Often, the diagnosis is Patellofemoral Syndrome or patellar joint dysfunction. Okay. All right. So Patellar Tendinopathy, this is also another pretty common condition, right? Tendinopathy, so pathy refers to there's some kind of pain. So you might see patellar tendinosis, right? Or patellar tendinitis, right? So there's inflammation and maybe the pain is minor. But, so when you read tendinopathy, there's, obviously going to be dysfunction to the level of pain. So these are going to be generally from, like basketball, jumping, quick decelerations, like soccer, rugby, you're running and then you stop and then you run and you stop. Obviously, anything where you have to jump a lot, maybe to some degree volleyball, not so much running, but there's more jumping. Basketball, of course, is running and jumping. And of course, running. So, this is when the patellar tendon, which runs from the anterior surface of the patella to the tibial tuberosity, right? That big bump just below the patella, right? So if you feel like where your kneecap is and you head south towards the foot along the top of the center, right? You'll feel this big bump, this big bony bump. That's the tibial tuberosity, all right? And so if the tendon, which is running, over the top of that, gets inflamed, there's going to be a lot of pain. There's usually some inflammation and swelling. It's often tender to the touch, but not super tender to the touch, but it's more about like, again, maybe going up and down stairs, walking, standing for periods of time, right? Will often feel very stiff. That's one of the key signs is there's a sense of stiffness. Like knee flexion and extension can be difficult, if not painful, right? So what I've noticed is that it's usually sharp when they're active and not constantly sharp, but they'll say like, I move a certain way, or every now and then I'll be walking, or I'll do something and I'll just move a certain way and I'll get this jolt of like this sharp stabbing pain. And then after that, when they're resting or inactive, then it's dull and achy. All right. There's usually some swelling. If they've had it less than 6 months, I would just assume that there's heat. Right. So one of the things you can do is you can kind of pinch along the length of, you can look this up on the images, either on Canvas or you can look online for where the patellar tendon is, and you can kind of just gently pinch, your index and thumb along the course of that, and it will often be a little bit sore, and it might even feel a little bit hot. You definitely want to palpate the rec fem, the rectus femoris. You want to palpate the quadriceps. You want to do the Eli's test, which we've seen. Obviously, the sinew primary meridian channel assessments, of course, are always very helpful. You can test the quadriceps as a group, which we've seen. And then look for extensive foot pronation, right? So is the foot like really falling in? Maybe they have fallen arches. You see this on people with often who are carrying around a lot of weight. You know, their feet will kind of like collapse in, right? So you're obviously going to have to be working with the muscles that affect the leg and the knee. And so one of the things you can do is differentiate from an ACL injury or tibial stress fracture. And these are generally going to be severe, right? So if you just palpate like the tendon, the patellar tendon, and the pain is not severe, or even significant upon palpation, but then they describe like all these other activities that are really painful, then it's probably not patellar tendinopathy, or patellar tendinopathy is secondary to these other issues, which we're going to talk about a little bit later on. So again, like the other condition, stomach and spleen sinew meridians, because these bookend the patella and the patellar tendon. The motor points are there to take the pressure off. Like, so what you want to do is like same with the pain around or under the patella, like for Patellofemoral Syndrome. What you're trying to do is you're trying to relax the muscles, particularly in the thigh, that are maybe overly contracting, and that puts, and again, all the muscles anchor via the tendons to these bones, these bony structures. So if you can relax the muscle and draw it out of the state of overcontraction, or if it's like weak and inhibited, and therefore it's not able to create stability for the knee, so the knee, you know, because it's actually not the skeleton that creates the major stability, it's the muscles that generate stability, that hold things kind of in place. So if you can relax the muscles, they're not pulling on the tendons, which are then pulling on these, there's creating a lot of tension on these bony structures, right? So we're trying to relax the muscles so they're not pulling the tendons tight. That's putting a lot of pressure or tension on these bony structures, and obviously on the tendons themselves. So that's why we do these motor points, is to relax the muscles so there's less tension and stress on the tendons and the bony structures, right? And then of course then the ligaments, right, that are holding all this together. So that's why we do a lot of these motor points, including stomach 34, 33, and 32. Obviously palpate, you know, and one of the things you can do to learn, to shorten your learning curve is sometimes I'm not sure like really what I'm feeling under my fingertips. I'm like, well, it just feels like muscle. I don't know. Like, and then I palpate sort of in the neighboring area to compare. Does it feel tighter or harder or more mushy and yielding? I don't know. Like some days my fingers feel like bananas. So I'm not really getting much information. So then I just do it anyway. And then I go back and then I palpate again. And I'm like, oh, wow, yeah, actually, this does feel different now. So sometimes you just learn by doing, because just some guy on a Zoom call said, hey, go try this, right? Right. So those are often very, very effective points for relaxing the muscles of the quadriceps, especially along the stomach channel. For a lot of knee issues, especially the patellar tendinopathy, points above and below, like named and numbered points, so like stomach 34 laterally, spleen 10 medially, spleen 9, liver 7 medially, stomach 36, gallbladder 34 laterally. You can hook these babies up to E-stim, points above and below, and it's really useful getting that chi flowing through there. Another way to do it is to kind of is needle the knee eye points, right? The medial and lateral Xi'an points, and then wire those babies up with E-stim. That's really good. You can also just needle along the patellar tendon, right? And alongside the tuberosity, and you can do E-stim on those. Really nice. Or direct moxa. Even if it's like there's inflammation and heat signs, like just like 3 to 5 moxa, really just get the chi and blood flowing that actually help decrease inflammation. I mean, I wouldn't do more than like 5 mux on each side. That should be plenty, because you want to stimulate chi and blood flow to nourish the area, and that actually helps reduce inflammation, right? I mean, I wouldn't do like moxa on the needle, you know, like insert in there if there's inflammation. Now, if there's an abundance of cold signs, then I would do moxa needle, okay? And again, you can also do cupping and gua sha on any muscles of the thigh, you know, quadriceps in the front, hamstrings in the back, maybe even the IT band, not so much, but you can check it out. Cupping and maybe gua sha are also really nice in this case as well. Again, a lot of the tongue points are the same as patellar femoral tendon issues. So like shin yi, shin shi, knee eye, heart knee, excuse me. On the elbow, really nice. There's also a 2-point group on the middle finger, so you can look these up. Physical therapy is obviously really good. These tongue points, I have to say, they are really effective, really effective. And of course, channel balancing points along the opposite elbow, very helpful. If it's bilateral knee pain, then you would do both elbows, right? You know, spleen is by the first system's balance, right? Spleen is tie in, so do tie in of the arm, lung. So maybe around like the medial knee crease, elbow crease around lung 5 area, really helpful. And then obviously, since the patellar tendon moves distally towards the foot, and if you imagine the foot is the hand, so you could needle around lung 5 and then needle along the lung channel moving distally towards the hand. Really helpful points. Stomach relates to large intestine, so same thing, large intestine 11 and then moving distally, like towards large intestine 10, you know, maybe even 9. Really useful points. All right. And then obviously your primary meridian and sinew meridian involvements, you want to test those out. Bachman knee points, kind of okay. I put them in here because some people have good success with them. I don't really have a whole lot. This is one case in which the shoestring combinations do seem moderately effective, right? So you would be doing stomach 43 on the affected side, right? And then large intestine 3 on the opposite sides, spleen 3 on the affected side, lung 9 on the opposite side, right? These are the shoestring points. Cupping on tight thigh muscles is fantastic. Topical liniments, also very good. Really good stuff. All right, any questions about that so far? These are kind of like your garden variety knee pains. For most of these, for these 2 conditions, for most of these patients that come in with these, they're going to be dealing with some predominance of wind, cold, or damp, not usually heat. So herbal formulas that are, you know, that guide to the knees or the lower extremities are really good. You know, ones that focus on, you know, these helping with the external pathogenic factors, driving out this kind of influence that stagnates the chi, as well as, you know, points in general that deal with, you know, wind and cold, wind and damp, right? Cold, damp. So, you know, those are found in Machocha. You can look those up. But frankly, if there's a lot of cold, you know, you can moxa and needle the luo junction points are also very good. What else is good for cold? You know, certainly like direct moxa around like the local area, certainly on either Asher points or named and numbered points, right? Stomach 36, gallbladder 34, medial and lateral Xi'an, right? Spleen 10, spleen 9, yeah, liver 7, right? These are all nice. All right. Any questions about those? All right. So bursitis of the knee, sometimes known as knee bursitis. And then there's something called the Pes Anserine. It's actually Latin for goose foot, because this is like this massive tendon that's a group of 3 tendons feeding into this like large tendon, which attaches just around the area just below spleen 9, like sort of between spleen 9 and liver 8. And it looks sort of like a goose's foot. And these are the 3 tendons of, I think it's like say grace before dinner, right? So it's the sartorius, the gracilis, and the something tendinosus. Oh shoot, I've forgotten the other one. I know it's the
Semitendinosus.
semitendinosus. Thank you. I think it's probably even in your notes. Yes, semitendinosus. Yeah, they say grace before dinner. So it's the sartorius, the gracilis, and semitendinosus. And these all kind of converge into like one giant tendon that looks like a goose foot, and that inserts in the area around. It's just distal to like the condyle in the area of like liver 8, spleen 9. And boy, let me tell you, when you palpate that area, your patient's gonna feel it, man. So that's how you know. That's how you know. And this is very common. It's becoming a lot more common. So this tendon kind of like goes right over the bursa, one of the bigger bursas of the knee. So usually there's some kind of acute trauma, or there's some kind of repetitive stress. You know, maybe they're like, especially like people in the military, you know, you've got like 50 pounds of battle rattle and, you know, all this other crap, right? Yeah, John knows. I mean, you've been there and done that 100 times or more. Yeah. So this puts a tremendous amount. Remember, we were saying, you know, like all this mass on your torso, this weight on your torso puts a lot of stress on your knees. Plus, you're wearing boots, and then, you know, all kinds of stuff. So people like maybe they're a guard and they have to like walk like a rounds, or, you know, they just have to go up and down a lot of stairs, or they're an athlete, right? So it may be some kind of acute trauma, like in soccer or rugby, or maybe even basketball, or maybe baseball. You know, you get hit with a ball like in the knee, that really hurts. There's really nothing quite like that sensation. Yeah, or, you know, repetitive stress. They also boxers, right? You know, so or CrossFitters, of course. You can put CrossFitters in all of this. So you want to be careful. You want to be careful about differentiating this from a medial meniscus tear, and we're going to talk a little bit about how to do that. But basically, if it's just the bursitis of the knee, if it's just Pes Anserinitis, basically your assessments here are gonna be it. With the medial meniscus tear, there's a couple of tests that we'll go over later. But basically, if you palpate around the knee joint, so if you have the patient lying down, right? So here's their patella, right? Their patella is like sort of like where my mouth is, right? And I'm looking at them. Like, so what you see is the medial side of the knee, right? So let's say they're on the table, and then you put a bolster under their knee to open up that joint. And if you palpate, if you press through this joint, right? If there's a lot of pain like in that joint, it's probably more medial meniscus. The Pes Anserine is going to be, so here's spleen 9. Yeah, let's say, so here's the joint. So here's like liver 8, here's spleen 9. In this area is where the Pes Anserine tendon. So it actually comes down over the medial side of the knee, past the patella, past the joint, and anchors below the joint. That's what gives it its stability, right? So it's going to be pretty intense upon palpation in that area. Okay. All right. And there's probably going to be some kind of pelvic imbalance, which is usually leading to a shortened sartorius muscle, and very often semitendinosus muscle. All right. There's almost always foot pronation as well. So the spleen and liver sinew meridians are going to be the primary ones to treat. And then you can also look at the motor points or trigger points for the sartorius, the gracilis, semitendinosus. I learned it as say grace before dinner. right? So sartorius, gracilis, semitendinosus muscles. You definitely want to check out the rec fem. You definitely want to check out the vastus medialis and lateralis. Sometimes the glute med, glute min, which are often kind of tested together, as well as like some of the adductor muscles in the upper thigh, right? Like the muscles that allow us to like bring our knees together, as well as the popliteus, which is a muscle sort of that goes transverses across bladder 40, right? These might test weak as well. Master dunk points are outstanding for this. Channel balancing points are pretty good. Points above and below with E-stim are really good. They have to rest. I mean, they have to do what they can to rest. I will often have them either on herbs, but I definitely are going to have them doing some kind of like applying some kind of dit-dat-jow liniment. It's so essential. They've got to baby this baby. They have to do what they can to stay off it. Auricular points are actually pretty decent for the knee. There's a couple of knee points that you can do on the same side or opposite side. You can kind of test. What I'll often do is I'll put a couple of points in one ear. Like, let's say I'm not sure which side to do. So like, let's say they have left knee pain. So I put a couple of knee points in the left ear, and then I have them get up and walk around. I have them walk up and down the hall. And then I take those out, and then I put the other two in, and I have them walk up and down the hall and see which one they notice more. And then I'll do the ASP needles in that side. Okay. But topical liniments, they got to be putting liniments on this baby like 3-4 times a day. Maybe if it's like severely inflamed, you know, ice for 5 minutes or so, and then alternate that with some heat. And this is somebody that, you know, again, 8 to 9 to 10 out of 10 pain 3 times a week, you know, 6, 7, 8 out of 10 twice a week, you know, maybe 5 out of 10 twice a week, you know, 1 to 4 once a week should be fine. This is also an area where you can do the sinew meridian Jingwell gathering point and then surround the area with superficial needling. Again, the sinew meridians are superficial, so maybe 2 fen, right? And then surround that area that's in pain, right? And then leave that in for like 30 minutes. Really helpful. Really helpful. Right? This is one of these things that actually is, the older the person is, the longer it's just going to take, right? And so we have to sort of manage their expectations and say, okay, I think somewhere around, like if I'm seeing you twice a week, somewhere around the 2-month mark, you're going to start to feel like 1 month mark, they should feel like a fair amount better at the end of 1 month. 2 months, they start to feel a little bit more substantially better. But again, they have to limit their activity, and then they have to like apply a lot of liniments or plasters. Okay. All right. Let's do one more, and then we'll take another quick break. So this one is a little bit complicated, trauma affecting the ligaments. So for your patient that comes in and says it's bone on bone, or people that have had ligament damage or severe tendon damage, you know, acupuncture is only going to be really helpful if they can come in really frequently. And again, it also depends on what grade of damage they've got done. So anytime they've got any of these positive assessments, right? So a history of forceful, so this is towards the bottom of page 8, history of forceful twisting movement or injury, possibly involving trauma of the knee directed medially. So they get hit from the outside of the leg, pushing their knee into like, so here's straight, here's lateral, here's medial, it like bends this way, right? That's very stressful to the medial collateral ligament, right? The ligament that goes up and down like the inside of the knee. So here's the medial part of the knee. It goes this way, right? So here's the head of the femur, and then the tibia, right? So it goes this way. And so that pushes that, so, you know, it pushes that force that way. Anytime there's like grade 2 or grade 3, you're not really going to help their ligament heal that much. You can help them deal with the pain. You can help them deal with the psycho-emotional issues. You can help them, you know, maybe relax their shin to be more patient. But it's not really going to help the ligament heal all that much. Occasionally you'll get like some miracle, which is great. So shoot for it, you know. But when I'm talking to my patients, if I suspect they've got any kind of trauma to their ligaments, you know, because I've gone through these tests that are listed at the bottom of page 8 and the top of page 9, they have to see a doctor. Well, I don't like to see a doctor. I don't care. I'm not going to treat you unless you see a doctor, because I need to know a little bit more about what's going on. I think it's pretty serious, and this is something that needs to be addressed because it could have severe complications later on in life, and it may interfere with your ability to walk. So if it's a grade 2 or grade 3, it's probably going to be beyond what we can do unless we're seeing them every day for a couple, 3 weeks. That's just the way it is. That's just the way it works. You know, herbs can kind of help. You know, liniments like jungu shui and other like bony, you know, things for bones, because ligaments, again, are more like bones than tendons. So anything that's good for bones, and jungu shui literally means, you know, bone healing water or healing bone water. Like jung means to correct, like the zhengqi, like to correct or make right, rectify. Gu is bone and shui is water. So they've got to see a doctor. They've got to get this examined. We got to figure out what grade this is. And that also is going to affect, you know, what you tell your patient in terms of, you know, what you think their prognosis is with acupuncture. So if it's a grade 2 or grade 3, I'm going to tell them, look, you know, you're going to need more than what I have to offer, but what I have to offer can help you in this way. I can help alleviate some of the pain. So, one second, John. Alleviate some of the pain, maybe help speed the healing process, and maybe help with your mood and attitude. But you also need more help than this. Yes, John.
If a patient comes in with a grade 2 or 3, they're going to likely be using crutches, would you say?
Not necessarily for grade 2. Grade 3, you know, they may even be able to get around without a cane.
Okay.
But if they're walking with a cane, it's probably grade 3. Yeah. Yeah.
Or if they're favoring the injured leg.
Yeah. I mean, because some people are pretty tough, especially women. A lot of the sort of middle-aged female patients I have, boy, they are tough. They put the rest of us to shame. And I hope this doesn't sound sexist. It's just an observation. Especially women who've had kids. Like, it's like, well, you know, I was hit with this hammer and it's kind of sore. You know, it's like, and I'm like examining them, just like, oh my God, you know, like, but they're like, it's a little uncomfortable in the morning. So, you know, you have to be careful about like how people present, you know. Yeah. So, Leggy talks a little bit more about grading the ligament sprains. The ligaments that you want to primarily, the ones that you're going to see the most are the MCLs and the LCLs, actually, excuse me, and the ACLs. I put the LCL lately because I put the LCL in here because lately I've been seeing a little bit more of that, but that's like mostly for people who like play football. But what you usually will see is the medial collateral ligament or the anterior cruciate ligament and medial meniscus. Those are like the big 3. Those are the big 3. So the MCL, that stabilizes the knee against lateral to medial forces. So from the outside of the leg in. So if you're playing soccer, even basketball or football especially, you know, you get tackled, or soccer, a slide tackle, or, you know, people with like really large or heavy dogs. I remember one time I was at a park in New York, and and somebody's bulldog, like, it just totally blindsided me. I didn't see, this thing is like a fire plug horizontally. This thing was like 80 pounds. And he just like bashed into my knee. And I went down, and because I had like knee issues before. I was a catcher. I used to play baseball. And I could just feel it pop. And I was just like, frack. And this 80-pound bulldog just like wanted some love and just came charging over, like blindsided me, and just my knee just like buckled inward. And thankfully I was actually in acupuncture at the time, and he fixed me up in like a week. But my God, like, so, you know, any kind of like lateral to medial, you know, impact can really put a tremendous amount of force on the MCL, which is this ligament that runs longitudinally that stabilizes the knee between the femur and the tibia. So that's really common. The ACL is really common when people are like, there's impact like from, you know, like pounding against the ground, like taking a strong step and then twisting, right? As well as the medial meniscus, which is injured in the same way you'd injure a MCL. So the meniscus and the ligaments are really considered avascular, which means they don't get a lot of circulation to them, right? There's not a lot of blood that is circulated into this tissue. So they don't get a lot of chi, they don't get a lot of lubrication. And as we get older, they get drier and more brittle. Again, it's a collagen-like tissue. So this is why I think the really e-stim is so good, because collagen, interestingly enough, the proteins in the collagen are phenomenal conductors of electricity. And here's the weird thing. They've even discovered that the collagen actually generates a small electrical force. It actually generates an electrical field. It's so weird, right? So that's why I think e-stim is great for ligamentous issues. Okay, so again, you know, you really have to manage expectations. I would say if treatments are not getting better after like 8 to 10 visits, or they start to get a little better, but they don't, but then it goes back down in terms of like, you know, like they get less pain and then the pain comes back up, or they start to make improvements in terms of their flexibility and strength. But then, you know, those benefits only last like maybe a day or two, and you've treated them like 10 times. They really need a more structural solution. PT, maybe surgery. You know, they should definitely get some kind of consult from an orthopedist to see, you know, what kind of structural work they need to get, because they need more than what you have to offer, right? So again, history of forceful twisting or movement, possibly impact trauma. There's a lot of pain upon palpation, and I mean like pretty significant amount of pain. There's going to be some swelling and stiffness. If there's no swelling and no stiffness, then it's not this, right? It's probably maybe just, it's probably just like a little bit of arthritis, or they've had like, you know, like some impact, but it's like minor and it's not really, you know, affecting them that much. So, or it could be just like a lot of kidney chi deficiency. There will usually be some kind of clicking or catching sensation, because especially with a medial meniscus tear, there'll be like a piece of the meniscus might tear off or break off, and that's floating around in that joint area. And boy, they'll tell you, oh, I move a certain way. You know, it's fine most of the time, but I move this certain way, and it's like this like hot lightning going through my knee, right? There's probably a piece of tissue that's come loose. Either a piece of the ligament's torn off, or a piece of the bone has been ripped off, or more than likely, 95% of the time, it's a piece of the medial meniscus, right? So there's Valgus and Varus tests, so we can look at those, as well as drawer tests, and then the Apley's test and the compression test and Mcmurray's test. So let's take a look at those, and then we'll take a break. Let's see here.
How reliable is test number 11?
Oh, it's 100%, 100%. So very briefly, I just got, I was like, I was kind of like just typing along, and I was thinking, oh, Ouija board. And then I was like, oh, you know, like I looked up Ouija board, like, it was like, where was this invented? It was invented in Baltimore. And what's weirder, and for those of you of a certain age who are familiar with Baltimore, when I was like in high school and like college age, we used to hang out after the bars would close at 2. We used to go to this place called the Buttery. It was like this little diner. It's a 7-Eleven now. It was vacant for like a long time, but it's right near that big museum. But it's in the corner of Charles and Center Street. What's that big famous hoity-toity museum in Baltimore City? It's the name after like some family. Anyway, my brain's turned to mush. But at the corner of Center and Charles, there's a building there that like occupied the Buttery, and it was in that building that actually they invented the Ouija board. So I was like, wow, that's cool. God, spent like a gazillion nights in that place. All right, so yeah, so let's look at some of the tests here really briefly. Let me see if I can pull these up.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct.
In this.
Okay. Can you all see that? Yes? No?
Yes.
Okay, thank you.
Yep.
So I'm going to demonstrate the valgus stress test for medial collateral ligament injury in the knee joint. Hi, and welcome back to Physio Tutors. The valgus stress test has been evaluated in a study by Harry Lane et al. They rated the sensitivity at 86% and the specificity was not reported. To conduct this test, have your patient in supine lying position with the legs fully extended. Now, with your patient in supine position, instruct him to relax as much as possible during the test. With one hand, grab onto the lower leg just above the ankle joint, and the other hand is used to fixate the femur. Then, slightly externally rotate the tibia and perform passive abduction in the knee joint, and thus putting stress on the medial collateral ligament. You are looking for excessive gapping on the medial side and the reproduction of pain. Consequently, perform the same test with the knee in 20 to 30 degrees of flexion. Again, you're looking for excessive gapping on the medial side and the reproduction of pain. Take a look at this table, which lists all of the structures you would assess with the valgus stress test in either position. All right, guys, this was our video on the valgus.
Okay, so what they're doing is, like, I'm accentuating the movement. They're pushing in and pulling out with the foot externally rotated, right? So they're pushing from the outside, again, because someone's going to have some kind of impact injury that's going to push their knee medially. So this is like an exaggeration of the movement, right? So this is medial, this is lateral, this is where their ankle is, this is where their knee is. You're going like this. Not very much, you don't need to do it. And when they say excessive gapping, it's shocking. Like, you can't see it in Kai. Like, Kai's knee is like, there's no excessive gapping. You just see the leg. It's almost even hard to see, right? Because he's moving it so very little. But man, if somebody is got like a MCL or a medial meniscus injury, it's shocking. Like, it'll really bend, and you'll actually see this almost like a fontanelle form in the joint space. It's crazy. Yeah. All right, so let's do the other one.
when school isn't a place you have to be, why not go to school where remote
In this video.
Okay. Let me try and share my screen. Yes, the Walters Art Museum. Thank you, John. It's driving me crazy.
I'm going to demonstrate the Varus stress test for lateral collateral ligament injury in the knee joint. Your tutors. Little is known about the diagnostic accuracy of this test, and the study by Harry Lane et al. Is of rather poor quality. They rated the sensitivity at 25%, but they failed to report any specificity percentage. To conduct this test, have your patient in supine lying position with the legs fully extended. To perform the test, instruct your patient to relax as much as possible. Grab onto the lower leg with one hand just above the ankle joint and fixate with the other hand on the medial side of the femur. Apply lateral rotation in the knee joint and perform passive adduction in the knee joints to put stress on the lateral collateral ligament. Consequently, perform the same test, but now with the knee in 20 to 30 degrees of flexion. When conducting the test, you're looking for excessive gapping on the lateral side of the knee joint, as well as pain reproduction. To interpret the outcomes of the Varus stress test, take a look at this table, which lists all of the structures you would assess in either position. All right, guys, this was our video on the Varus.
Okay, so as you can see on that list that came up, the valgus and varus stress tests can imply quite a lot of other things. I wouldn't really worry about that so much, because and again, I would recommend going back and looking at that table and maybe Googling those different conditions. Here's why I wouldn't worry so much about differentiating between if it's this or that or that or that or that. These very very refined diagnoses that are isolating very specific muscles and ligaments, because you're going to treat those things basically the same. Because from our perspective, there's a slight moderate difference between what sinew or primary meridian might go through this one particular muscle or tendon versus this other muscle or tendon, right? So there's that differentiation between what specifically the sinew and primary meridian might be. And as well as you can look up, okay, well, if I've got these 5 listed and 1 and 2 imply this one muscle, and 3 implies this other muscle, and 4 and 5 imply this other muscle. You can look up in that list that I gave you of what muscles relate to the different sinew meridians as well as primary meridians, and then go back and test those. So you're taking that hypothesis, well, it could be this, 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 or this from a Western medical point of view based on the Varus or valgus stress test. And then you're saying, okay, it could be associated with this particular sinew or that particular primary meridian, or this particular substance like chi blood, right? Or tissue, ligament, tendon, muscle. And then you'll be able to actually then go through your normal assessment and treatments, because the treatments won't really vary that much based on, all those 5 things or 7 things in those tables. You see what I'm saying? So there's going to be a lot of overlap in how you treat, regardless of whether it's this, 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 or that, like on that table. Remember that table that showed up? So a lot of your treatments are going to be relatively the same, regardless of that super refined diagnosis from a Western standpoint. Again, you always want to fall back to, well, if this test implies an imbalance here, okay, and that implies a certain tendon, well, that attaches to a certain muscle. So let's do that muscle test. Let's palpate that motor point. Let's palpate that potential trigger point. And that, okay, that's going to give me information. And then does that relate to a certain type of pain, which implies involvement of a certain substance, blood, chi, or a certain external pathogenic factor, you know, more cold, more wind, more damp, right? And then does that muscle or tendon, does that relate to a certain primary or sinew meridian, which I can then retest and treat accordingly? So that's how you can kind of like deduce down into a Chinese medical methodology, treatment strategy. Does that make sense? Right? So you're always going to be looking at, okay, well, if it's this, that implies the involvement of this. And if it implies the involvement of this, then here's the treatment strategy for that, right? Okay? All right. Why don't we take a break, and then we'll cover a couple of other little tests, and then we'll go through how to treat ligamentous issues and the meniscus. So let's break till 10 after. We'll come back at 10 after 11.
This is going to be the anterior drawer test to test for ACL tears. The anterior drawer test has a sensitivity of 92% and a specificity of 91%, according to a meta-analysis done by Benjamin et al. In the year 2006. These values are reported for a chronic situation, while the test performs way poorer in an acute situation. For the anterior drawer test, it is first recommended to exclude a PCL injury in order to avoid false positive results. So click on the video right here to watch the posterior sag sign, or click on the video right here to watch our video on the posterior drawer test. To perform the anterior drawer test, bring your patient's hip into 45 and your patient's knee into 90 degrees of flexion. You can fixate this position by gently sitting on the foot of your patient. Then palpate the joint line with your thumbs and try to move the tibia anteriorly in an explosive movement. This test is positive if the tibia translates anteriorly more than 6 millimeters, or if you experience a soft and mushy end feel. This was our video on the anterior drawer test. If you want to check out other tests for an ACL tear, make sure to watch the pivot shift right here or the Ligament test right here. As always, I hope this video was helpful to you. If it was, give it a thumbs up. Check out page www.
Dr. Donald Rosello of Championship Chiropractic in Las Vegas, Nevada. Appli's compression and Appli's distraction tests are tests for the knee. In these orthopedic tests, the patient is laying prone. We want to passively flex the knee to 90 degrees. When we are performing the distraction aspect, you want to place some light pressure on the back of the patient's thigh just to anchor their thigh to the table. You're going to grasp the distal ankle with both hands, pull upwards, internally rotate the tibia, then externally rotate the tibia. When we are performing Apley's compression test, we want to put pressure on the plantar aspect of the foot, and we are going to press down, internally rotate the tibia, then externally rotate the tibia. When we are performing the distraction aspect, if there is pain in the medial aspect of the joint or the lateral aspect of the joint, that may indicate a rupture or an injury to the medial collateral ligament or the lateral collateral ligament. If there is pain when we are doing the compression aspect, when we are internally rotating or externally rotating, that can indicate an injury to either the medial meniscus or the lateral meniscus.
Okay. So again, I would practice these on anyone that you can eventually. You know, I don't know what your situation is, but see if you can practice these, or next time you go to get treatment, if you're getting treatment still, like maybe have the person perform on you, or maybe they'll let you perform it on them. Right? These are actually really helpful tests. Again, nothing is 100%. And also, if grade 1 and grade 2 can generally heal fairly well, but slowly, grade 3, if there's any kind of grade 3, you know, if they go and get a diagnosis of grade 3, that's going to require almost 100%. That's going to require surgery, right? So these are some of the different tests that you can use. There's one last one called the Mcmurray test, which we can take a look at that. Do I have that on here? Let's see. Or is that later?
It's in the notes.
Yeah.
It's number
9.
nine.
Oh, here it is. Here it is. Okay, we'll take a look at that. It's not a great test, but it's not bad. Let me just get past this ad. Okay, let me share my screen.
Going to be a video on the Mcmurray's test for meniscal damage. The diagnostic accuracy of this test was as low as 63%, which means that only 63% of all the patients were correctly diagnosed by musculoskeletal clinicians. To conduct this test, have your patient in supine-lying position with the tested knee fully flexed. Then, rotate the tibia medially and bring the knee into extension. You want to repeat this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion and laterally rotate the tibia. The anterior half of the meniscus is not as easily tested with the Mcmurray test because the pressure on the meniscus is not as high. This test is considered positive if your patient experiences clicking, locking, or pain in the knee. All right, guys, this was our video on the Mcmurray's test. Make sure to also watch the Acl test and the Patellofemoral test right here that also assess for meniscal damage. This was Kai. This is going to be a video on the Patellofemoral test for meniscus lesions. Been described as the most accurate test for meniscus lesions by Carvalhos et al. In the year 2005. However, there has been a new research by Goossens et al. In the year 2015 with a higher quality that states that the sensitivity is as low as 64% and the specificity is as low as 53%. This means that the Patellofemoral test is not an accurate test to detect meniscus lesions. However, the Acl test or the Mcmurray test do not perform much better in this regard. So when you suspect a meniscus lesion from your patient history taking, you can still perform those tests, but eventually you might want to send your patient to get an MRI. Like with any provocative test, you first want to check the uninjured leg before you move on to the injured leg. To perform this test, have your patient stand on the injured leg, which is flexed to 20 degrees. Your patient may hold on to your arms for support. Then rotate over the tibia 3 times on each side. Okay. This test is positive if your patient is complaining about pain in the joint line during the rotations. All right, guys, this was our video on the Patellofemoral test. I hope this video was helpful to you.
Okay, so those are a bunch of tests. Again, you know, with any joint, there's a lot of different forces acting on that joint at once, so it's not always easy to isolate one very specific tissue or piece of anatomy. You know, by and large, they seem pretty helpful to me in my practice. The Thessaly test, actually, he says it's not like that great of a test, but when there's pain, especially like twisting inward, whew, yeah, it's pretty obvious. The biggest treatment you're going to give your patients for any kind of damage to the ligaments is going to be rest. Ligaments, of course, since they are a very dense tissue, they aren't well innervated. There's not a lot of vascularization to the area, so that's going to require a lot more rest because they're not getting a lot of what they need to heal very quickly. Again, there's not a lot of nerves that go to it. There's not a lot of vascularization for it, so they don't get a lot of blood supply. So herbs are moderately effective because, again, they go through the bloodstream. But rest is a big one. You know, physical therapy is really important. The San Huang San herbal ice is very helpful. Dit Dat Jiaos or Zhonggu Shui is really helpful. We'll go over more specific liniments later on in the course. I put in there number 4, sort of as a joke, but really anything you can get from the store with the word miracle on the label, like that's you want to take that. All right. Again, the E-stim, very helpful for low to moderate grade damage to the ligaments above and below. There's another way of also treating, like if you can palpate along the area, if you can kind of isolate the area of pain, either for the medial collateral ligament, somewhat about the meniscus, we'll get to that in a bit, but if you can kind of palpate that sort of line of pain, if you can palpate and isolate that ligament, you can needle just above it, very obliquely, transversely, right? And then in the other direction just below it, right? And you can E-stim those, really nice to get a lot of, like, a little bit more chi and blood into that area. Bleeding is very effective for ligamentous damage, meniscus damage, anything where there's a lot of like inflammation. Wet cupping is extraordinary. I generally don't do it like, if you do it like right over the area, do it with just a really small amount of suction, just enough suction to just draw a little bit of blood into the cup. You can do above and below with a little bit stronger cupping. But if you do wet cupping or bleeding along that area where there's a lot of swelling, inflammation or pain, just do a very gentle amount of suction. Too much suction can be really uncomfortable and maybe potentially damaging to the patient. But phenomenal. And interestingly enough, I didn't mention it here. So for really any knee issue, but it's also extremely good for meniscus and ligamentous damage, is wet cupping, like bleeding cupping over bladder 43, the outer bladder line point for the pericardium. This is really interesting. Like, I came across this, and it's I can't fully explain why, but it's really profoundly tremendous. It really is amazing. I would say not 100%, but I would say about 80% of my patients that come in with knee pain, and I bleed that point. And if you think about like the pericardium's role with the heart and how it absorbs the emotional shocks and blows to the heart, maybe that's why, you know. But I like lancet a couple points on it, and I put the cup on there and draw some blood out, like, you know, maybe 1/8 of a teaspoon, 1/4 teaspoon at the most. And it's phenomenal. It really takes a lot of pressure off the knees. So if it's medial ligament, spleen 8, spleen 9, spleen 10, you can also join these with E-stim. If it's lateral, gallbladder 33, 34, 40, you can also join those with E-stim. Really good. Channel balancing points, master dunk points are very good for these. Again, you want to isolate whatever sinew and primary meridians that are affected. And again, if you can kind of isolate or look online at the pictures of the anatomy, points just very transverse obliquely above and below the ligaments. Like take like 1.5 inches, or you can start with 1 inch just to get the handle on it, but eventually like 1.5 inches, 2-inch needles, and you just needle these just above and below the ligament, or if it's this way, you know, above and below the ligament, with or without E-stem. Really, really helpful to get like some chi moving through that area. And again, topical liniments are very, very effective. All right, so those are the mostly like the what were we saying? Like the collateral ligaments and maybe even the MCL. All right, so with the cruciate ligaments, the ACL most commonly, PCL not so much. So the anterior is the anterior cruciate ligament and a posterior cruciate ligament, right? So basically what this does is it holds the knee joint in place by kind of weaving through the center, connecting the tibia and the femur. And so it kind of like starts in the front on the side and then kind of like weaves its way through the middle and then connects to the opposite side and the opposite, like, and in the back, right? So the anterior cruciate ligament starts in the front, weaves its way through, and then goes to the back. Posterior, it's in the reverse. And this helps to keep the tibia and femur, right? So if this is anterior and that's posterior, it keeps them from slipping out of joint this way. And it kind of like winds through the center. It's really a fascinating structural device. I mean, like whoever designed the knee, like it was a pretty good touch. They could have made it a little bit stronger though. It would have been a little nicer. But you know, can't have everything. So my suspicion is though that people who are very active at a young age and like get a lot of like kidney nourishing foods probably are going to have a lot healthier ACLs and LCLs, PCLs than we do now. But very, very important ligament. These are generally messed up for people who have like a lot of like contact sports or sports involving a lot of running. Most people are not going to damage their ACL, especially their PCL, unless they like fall off a ladder, maybe are running and they trip and they really bang against like a rock or bang something hard, like they go down really hard, unless they're older. You know, ACL is like one of these injuries that's generally experienced by athletes. Most people like garden variety patients are not going to deal with this. Most garden variety patients are going to be dealing with the MCL or the medial meniscus. That's in the meniscus probably even more. ACL is like, it's a pretty heavy duty injury. This is like, you know, football players, rugby players, soccer players, or somebody's like taken a really bad fall and kind of twisted at the same time. It's going to be pretty severe pain with sudden onset. And then after that, they're going to have a lot of difficulty moving it, a lot of difficulty flexing and extending it. They will generally know it. They'll generally say, oh yeah, I knew something really bad happened because there was a profound popping sensation. And they'll probably hear it. It's quite loud when this goes, and it's going to swell up. This is not an injury that hides itself well. Like there's going to be a lot of swelling for 3 days, maybe even longer. So there's the positive anterior drawer test, which we saw with the explosive movement forwards. And when you do this test, sometimes it's funny because it's not always that uncomfortable, but boy, will that, so here's like the patella, like here's the patella, and then here's like the tibia coming in, like, and then the femur is underneath. You'll see, like, normally it like go up like maybe like this far. You'll see this baby go like way up. It's like you're inside, you're like going, ooh. it's like one of those oogie kind of tests, like where you're just inherently, you know, the body should not be doing that. So when you pull up, like that leg goes like way up. It's like couple 3 inches. It's like, And you just got to like poker face it out. You know, you don't want to go, oh my God. Right? But that's a pretty positive sign. And that may or may not occur with pain. Right. So there's a couple of the tests, the Lachman test, the drawer test that you can use. There's also the posterior sag sign. It's not great, but it's okay where they're standing, and you'll see like the legs, like this sort of divot kind of appear. And it's a very slack knee joint. Again, the knee is about stability. So it's going to be very unstable to walk on. It's going to be like, you know, I wanted to put weight on it, but it feels like it's going to give. It's that kind of thing. Now, what I have found, especially in older folks, not always, but very commonly, when there's an ACL tear, usually the medial meniscus will be damaged in the process. So treatment is very similar. You know, there's a nice shoestring point, hussy point combination that you can do. Basically, it's kidney 3, kidney 10. You can also join these 2 points with E-stem. Very helpful. And then if it's the PCL, which is pretty rare, then you would do like bladder 65 and bladder 40. And you can combine those with E-stem. But more often than not, it's going to be the ACL, the anterior cruciate ligament, also with medial meniscus damage. And so with the ACL, you know, it's like deep in the joint there. So, you know, it's kind of hard to like kind of get a lot of stimulation deep in there. You can use the sinew meridians, which are okay. That does alleviate a lot of pain and does help with the flexibility quite a bit. Also, the medial and lateral Shion, the calf's nose, like stomach 35 and its medial complement, needling towards the posterior center of the knee around bladder 40. You can also use moxa needle on there if it's fairly chronic. Maybe they healed it a long time ago and it's flaring up again. They're older, or it's like it gets worse in the winter. So moxa needle is really nice. Liver 7 is a really good local point. You can combine that with spleen 9. You can also do E-stem. You can do points above and below with or without E-stem. Those are also really good. And the master dunk points are good. Again, if it's a severe injury, they're going to need surgery or some kind of structural repair. If it's minor to moderate, they've got to rest it. Liniments applied like 3-4 times a day, and then some stretching exercises to keep it limber. And those would mostly be like just very gentle, like knee flexion and extension exercises. And if they get better with it, then they can do with like resistance bands, where they can kind of like wrap the resistance band around something and then like just sort of stand up and, you know, just lift their leg up like this to strengthen the quadriceps and also to get, you know, some blood flow through the knee. Okay. Meniscus injuries, these are fairly common, more common than the MCL, the medial collateral ligament, more common than the anterior cruciate ligament injury. This is like your garden variety, like serious layperson injury that is a non-athlete injury. This is also very common among athletes as well. Again, you're going to use like the Thessaly test, the Mcmurray test, the distraction test, excuse me, the grinding test, not distraction, like the Acl, right? So you're going to have the patient supine, right? You bend their leg up, 45, and you press down and twist laterally and medially. Generally, you know, the distraction test with rotation, that's more ligament damage. The compression test is going to be a little bit more indicative of meniscus tear. Okay. Now, if you look online, you know, you can see the various grades of meniscus tears if that interests you. If you're not squeamish, you can look at those. If it's a minor meniscus tear, acupuncture can help. Needs to be frequent, 3 times a week, you know, maybe a couple months. That's just the way it is. These tissues, because, you know, unless the person's in constant bed rest, they're all, you know, they're at some point they have to get up and walk around, and that puts a lot of pressure on the knee, which puts a lot of pressure on the meniscus. So this is not a part of the body along, you know, again, hips, anything lower body, hips, knees, ankles, feet, you know, they don't get a lot of rest because just standing puts pressure on them. So, and if the person's overweight, that puts even more pressure. So they have to eat lighter. They have to avoid sour foods for all of these. They have to avoid a lot of like fermented foods, alcohol, sugar, anything that like digests really hot, right? They want to avoid these things. So no sugars, nothing that digests really hot. They want to stay away from sour foods, okay? What else? Yeah. And avoid a lot of sweets, okay? So again, you know, there's going to be some kind of history of injury or repetitive stress that puts a lot of pressure on their knees. You know, maybe they have to walk a lot. Maybe they have to go up and down a lot of stairs. Maybe they've done a lot of athletics. Maybe their hobbies include some kind of athletic activity like running or jogging. You know, especially if they're jogging or running outdoors, they might be running on some kind of uneven surface, which might put a torquing pressure, which then might put pressure on the medial meniscus. There will be pain along the joint crease. Again, you know, you have them lie down on their back, flex the knee just a little bit to open up that joint crease, and then just palpate the medial aspect of that from the patella down towards kidney 10. You're going to palpate posteriorly, and there will almost always be pain somewhere around liver 8, maybe even just above it or below it. You want to assess the sinews and primary channels because, again, you know, the location of the pain might say, yeah, well, it's definitely this, but, you know, when you have them do certain movements, it may not be an obvious sinew meridian that's involved, right? So you want to make sure you look for that. There will almost always be some restrictive range of motion as their body goes down into a squatting position or a sitting position or getting back up, you know, out of a chair. It's like, oh yeah, they have to like press on their thighs or lean on something to get up. It may lock up or feels like it's giving out. That's often a medial meniscus. It will usually click if there's a piece of the meniscus that's substantially broken off. Again, there's the Thessaly-Mcmurray test and the grinding test. So any type of like severe pain with the knee, I always refer them to a specialist to get some kind of scan, you know, because there's things that they want to rule out. And also just to make it more clear to them, you know, how much rest they really need to do. Resting is good. Icing it a little bit, you know, 5 to 10 minutes out of every hour. You can also then alternate that with heat. The San Huang Sun, right, the 3 yellow powder is a really good healing salve for that. I make some of my own, actually. Daniel Scryer and I have now been making some. We've got a slightly different formula, which we think is better. Really, I think it's phenomenal. It's like herbal ice, really good stuff. Sinew meridian treatments, especially liver 1, and I bleed it, is really good. Also bleeding and cupping bladder 43, you can see here. You can also try bleeding and cupping bladder 42 and 41 as well. On the affected side, if you can only do one, I would just do bladder 43. I think it's just phenomenal. And this medial knee pain, the Shinmen heart door located on the elbow, it's like just distal to small intestine 8. And I needle that as deeply as I can. Sometimes I just very gently peck against the bone and then pull back out a little bit so it's more comfortable. That's a phenomenal help, especially with the pain and the inflammation. And also, you know, I kind of combine that with heart 3 and maybe heart 8 if there's a lot of Shen disturbance. You can also combine it with pericardium 8 if that feels better to you, or upon palpation that calls out to you more. This is really good for like quieting and, you know, calming the mind a little bit, especially combined with things like yin tong and do 20. I definitely cup and bleed along either side of the affected sinew meridian trajectory, above and below. This really takes a lot of the pressure off in terms of stagnation of blood and qi. This really helps to also clear out a lot of the toxins that are building up, that are, all these fluids are being sent to the knee to protect it. 1 second, John, to cushion it. And so that can increase the stiffness. It also, that swelling can increase the pain. So this is really good for like moving out the fluids and the blood that don't need to be there. Yeah, John.
So the cupping and bleeding, this would be cupping and bleeding along affected sinew meridian.
Yes.
You would probably want to use a 7-star hammer.
You could, or just a lancet. Yeah. I massage a point, put a little cup on there, like with some suction, like for about a minute, just to get some like blood up to the area. Then I take the cup off, put it back on the gun. Then I, puncture it once or twice, then put the cup back on, and then bring in some suction to draw some of that blood out. All right. You can also do a lot of that oblique transverse needling along the knee crease, right? Posteriorly and anteriorly, above and below. So, look at the anatomical picture and then just palpate around, and you can feel sort of like where that medial meniscus would be, or just your best guesstimate. And then you can either circle the dragon and combine that with the sinew meridians, right? That's one way, circling that area of pain, combine, during the course of your sinew meridian treatment. Or you can also like palpate that like groove of pain, kind of mark that out. And then you can do needles like transverse oblique, right? On either side of that, especially with E-stim, really nice. In Reeves's book, I don't have it in front of me, but he talks about like these sort of liver 8 and then kind of like a posterior liver 8. So you find liver 8, and then there's like a point just like above liver 8 that's often very sensitive, and just below that, and he calls these like anterior and posterior liver 8. And you can very gently needle into that. If it's painful and they have that sharp pain, then pull it back out a little bit. And you can use E-stim on this, really helpful, really helpful. Or just let it be, which is fine. So liver 8, and then maybe just anterior to it and just posterior to it. Really some nice points. I forget how he said that, like sometimes I think he said he even went down to like peck the periosteum and then pull it back out a little bit to try and trigger some, and attract some qi and blood to flow into that area. I would try it out. It's sometimes pretty helpful. I know I like it with the E-stim, so that's really good. And then also, of course, like the medial and lateral Shion, those knee-eye points directed back towards kidney 10 or bladder 40, right? So if you're doing the medial Shion, you're aiming that towards bladder 10. If you're doing the lateral Shion, you're aiming that towards bladder 40. Have you guys ever done those points? Right. So for the meniscus and the ligaments, so here's the patella, right? So here's the tibia, here's the femur, here's the patella on top, right? Femur, tibia. And so here's like the medial side, right? So like here's say like liver 8, and then here's like kidney 10 up under there. And then so this would be like stomach 30, no, this would be like medial Shion, and then lateral Shion would be back here. So if you're dealing with like patellofemoral problems, or like the problems with the tendons and the tuberosity here, then when you're doing medial and lateral Shion, you're going kind of like up under the patella. You're directing it more superiorly. With these issues that are down here, you're going to angle the needle a little bit this way, right? So patellar tendon problems, right? You're angling it this way, like kind of going up under the tendon or towards like the tuberosity. So the angle is going to be more shallow. With these treatments, when you're dealing with the ACL or the medial meniscus, you're going to be angling it like deeper, right? Like more perpendicular. Does that make sense? Right? So you're aiming it on the medial side towards kidney 10. Like if you're dealing with like the patella tendon, right, you're angling it up this way. You're not angling it that way, right? Knee bent. Thank you. Ciao, ciao. You're going to be angling it like patella problems and tendon problems. You're going to be like angling it this way. You know, medial meniscus, ACL, right? You're going to be angling it more towards the center of the knee, like medially towards kidney 10, right? Like laterally more towards bladder 40, okay? So there's going to be a slight difference. And again, you know, for some, you might hit like something that's like sharp, just pull back, right? Maybe re-angle it. You go in about an inch. Think about like an inch. That's your rough guide, even on a petite person. And with E-stem, this can be really powerful. And then you can even combine this with like liver 8 or kidney 10 or both, and you can do those with E-stem. Okay. As well, you know, you want to take the pressure off of the knee and the tendons and the ligaments that are holding the knee together. So you don't want forces like pulling the knee away from that joint. So that's why you want to relax the muscles of the thigh and possibly the lower leg, like the soleus and the gastroc. But more often than not, it's these muscles of like the quadriceps, vastus medialis, vastus lateralis, sartorius, gracilis, semitendinosus, and then the hamstrings in the back. These, or the IT band, these are the ones that are more often than not going to be tight. I rarely treat gastroc and soleus motor points for knee problems. It's almost always the muscles that anchor the knee to the hip that are the ones that are like overactive and shortened and like pulling, you know, putting tension on that knee joint, like upwards. Does that make sense? So that's why motor points for the thigh are like really helpful. You can even do cupping to help relax the thigh as well, the thigh muscles and the hamstrings. Does that make sense?
Yes, thank you.
All right. And again, you know, ACL, MCL, LCL, meniscus, these are slow healing conditions. So we have to manage our patients' expectations accordingly. All right. I've given you a little bit more treatments here for like chronic and acute. You can look over those. It's pretty similar in all cases. That's why I said like, don't like worry so much if these tests, well, gosh, you know, I do this Acl's test or I do this, you know, like Thessaly's test or Mcmurray test, and like it could be these 5 things. You're going to treat those 5 things basically the same way. So it doesn't really matter. The only difference is like this target tissue needling where you're like locating, you know, the ligament or the area of the meniscus and you're needling adjacent to that area. That's the only difference. But even that can help. All right. I wanted to mention something that I kind of stumbled across, like this Baker's cyst. So things kind of come in waves. And like, I remember like a few years ago, maybe like 4 or 5 years ago, like I had all these patients with Baker's cysts. I was like, well, this is weird. So usually there's been some kind of trauma that's then provoked. It's sort of like the sand and the oyster that becomes the pearl kind of issue, where you have like some kind of trauma that maybe didn't like rock somebody's world, so they didn't take much note of it, but it created some kind of imbalance that over time like stimulated some kind of irritation, which the body then tries to protect itself from by creating a cyst. And these can become quite large. I mean, they can become like, you know, a large grape. And, you know, the cyst can be sometimes large enough because it's sort of like webbed into the tissue and the tendons. It can, like, all these adhesions can form. It's not just this like floating cyst in there. There's like this web of fascia that can grow around the cyst that attaches to the tendons, the nearby tendons. And then eventually it might even affect how much the person can flex and extend their knee. And sometimes it can even be palpable, like, you know, to touch, which was weird. I mean, this one woman had this like Baker's cyst. It was like massive. It was almost the size of a golf ball. And we did manage to shrink it considerably. E-stim is very good. So basically the assessment is pain or stiffness in the local area, especially around bladder 40, or in the area maybe just inferior to, just below, and just lateral to, again, towards the middle of the knee from kidney 10. So sometimes it's like right in the center, and sometimes it's a little bit more towards kidney 10, or just like a little bit below bladder 40 and kidney 10. Okay, anybody ever have any of these?
My mom did. She's had knee surgeries and replacement, and that was one of the complications she had.
Yeah, yeah, there's some like irritation with the hardware or the way that the knee is tracking, and the body tries to protect itself by sending this like really phlegmy fluid to create this cyst as like another, it's almost like another bursa. But it can become large enough where it actually interferes with one's ability to flex and extend their knee. So basically, also maybe a sense of fullness or stuckness in the knee. You certainly want to do your primary and sinew meridian assessments. What I found actually is really interesting is that if you needle, again, if you kind of like do this 1-inch needling towards kidney 10, towards bladder 40, medially and laterally respective, with e-stim is better, it can actually help to shrink this quite a bit. And then you can actually needle around the cyst. Like I've heard some people say you can needle into the cyst. As a beginner, I'd be really careful about that because you don't want to create like an infection deep in the knee. Yeah, John.
Just out of curiosity, Teresa said her mother had a Baker cyst. What would Western medicine do? Would they draw fluid from it?
Yeah, that's it. That's all they do. That's the treatment.
Mean,
when it gets horrible, then come see me and I'll drain some fluid out of it, and then I'll see you later.
but it's always on the back side of the knee?
Predominantly, yes. Yes.
Okay. So
Yeah.
in these other conditions, is it possible that in Western medicine that they would have to remove fluid because it's
Possibly.
from the knee joint?
Possibly, yeah.
Is that what, I'm just curious, what would be the origin of that fluid? Would that be damage done to?
What's the fluid that it accumulates as a response, right? It's like the body's trying to respond by cooling it, to try and cool the inflammation, right? Because fluid puts out, water puts out heat, fire. So it's trying to cushion the area, and it's trying to protect the area, and it's trying to cool off the area. Now what happens is if it's chronic enough, the coldest thing is bone. So then you get these calcium buildups, again, like on the vertebrae or on the bones, like the femur or the tibia, right? The heads of these bones, they'll try and like add more calcium and bone. Then you get these bone spurs, right? Which are very painful. But that's the body trying to protect itself, cool itself off. Yeah. Channel balancing points can be helpful for the pain. And liniments are moderately helpful, but you'd have to apply like a lot of moist heat. But what I would say is like, what's really helped is like medial and lateral Shion, that is the knee eyes, right? Stomach 40-35 and its medial equivalent with e-stim, as well as needling around or maybe onto the top of, like needling, just like not needling into, like, so going from like the back of the knee, they're lying supine with their leg up, so their knees bent just a little bit, and you can kind of needle over that area, even with some e-stim, and that can alleviate that a lot. So it's improving the circulation, right? You're warming the area, improving the circulation, and then reducing the amount of cold stagnation, which is what this Baker cyst is. And I'm sorry, I realized there's a little typo. It's not called a Bake's cyst, it's a Baker's cyst. Okay, all right. Let me just briefly mention about arthritis, as they say in Baltimore. It's rare that a patient under 40 is going to come in with arthritis. If they do, it's probably as a result of some kind of impact trauma, some injury that they've had to the knee that then was not given appropriate treatment. They probably overly iced it. And then they probably went back on it too soon, which then aggravated a lot of the tissues, depleted the chi and blood flow, which then led to a blood stagnation from deficiency, right? There's not enough circulation to keep things moving. There's not enough blood and chi to be circulated, so things pool up. And the other type of patient you'll see is somebody like, 50 or over. Maybe they've had a history of, like wear and tear on their knee, maybe from sports, maybe from, a laborious job that required a lot of like walking or standing or kneeling, or maybe a lot of exposure to the elements outside, or changing climatic factors, like I know a guy who like works for a beer distribution company, liquor distribution company, and he delivers beer and wine and all that stuff. And so he's in and out of a refrigerated truck, and then he goes outside in the hot sun in the summertime, and then or in the cold, and then he goes into a freezer, which is even colder than the cold, and then back out into like a heated truck, and he's driving and he's lifting stuff and he's like using the dolly, and so that type of thing that's wind, all these changing climatic factors, that's wind. So the Bachman knee points can be quite helpful for this. The shoestring points, pretty helpful. You're going to have to treat systemically and locally, like wind, cold, damp points, which you can look up in Deadman. Which you can look up in Machocha pretty easily. There's a pretty standard set. The Master Dunk points work really, really, really well for this. But again, blood moving, blood building, blood moving, and then points in the local area or systemically to expel the external pathogenic factor, especially the predominant one. So again, look on the earlier part of this notes, as well as the other notes for, okay, yeah, this implies a predominance of wind, this implies a predominance of cold, this implies a predominance of damp or heat, and so on, right? Yeah.
Time. Number 6. Is that supposed to be Korean?
Yes. So Koryo hand points are the Korean hand points. I forgot to bring the book down, but there's a really nice book. It's about this thick on using different points on the hand that correspond to different body areas or correspond to the different meridians, or both. There's a dude, I can't remember, Dan Lubinsky. Last name begins with an L. Shoot, I have to look this up really fast. It's Dan Lobash. That's it, Dan Lobash. So he and his wife, God bless them, they drive around the country in his RV doing workshops. Like he'll have it at like some hotel. He'll like rent out like some cheap little hotel room, and he'll park his RV in the parking lot, and he'll do these little workshops. And a number of times he's actually come to this like creepy hotel in Linthicum, and he'll like set up, and he's got a little dog, and he like rolls into town, and he does Korean hand acupuncture workshops using magnets. He doesn't use needles, he uses magnets, and he's got this little pointer device to help assess, and he's got these different types of magnets, and he's just like the sweetest guy. He's just like, I don't know, you look at him, he reminds me of like, with shorter hair, he looks like the Quaker Oats dude. He's just like the nicest guy on the planet. And he and his wife are just lovely people. So I haven't seen him around. I mean, he was pretty old, like when I was seeing him, like he'd roll through town. I mean, he was definitely in his 60s. I took like 3 or 4 of his workshops, And he's great. He's a really, really neat guy. So I don't know, look him up, see if he's still around. I haven't seen him like advertise for his workshop. So maybe he's retired. Maybe he's just like down in Florida or something, which actually made me think, you know, I should reach out and like contact him. He's just a really good dude, and very knowledgeable. And yeah, I would highly recommend it. It's yeah, so just looking back about the Baker cyst, you can get the sac removed, you can get the cyst removed, so it doesn't get filled back up. But you know, it's funny because I've actually had a couple people, 2 patients with Baker cysts where they got them surgically removed and they came back like about 2 or 3 years later, which sucked. So anyway, the choreo hand points are really helpful for arthritis, as well as these master dung points, really good. But they have to be combined with local and distal points to help expel the external pathogenic factor. That's a must. And there's a lot written about this. I've put some documents on your Canvas site. I can't remember. It might be in that first section, like resources or something like that. I have like B syndrome, like sort of simple, and then B syndrome comprehensive or complicated or something like that. You can look for those. Let me see if I can find it right now. Let's see. Under additional resources, it's not there. Oh yeah, under class 3, you'll see B syndrome simple and B syndrome comprehensive. That's under class 3 module. I don't know why. I used to keep that in the additional resources section. I don't know why I moved it to class 3. Anyway, so you can read through that. Machocha also has a lot of good stuff about that as well. Pretty simple, but honestly, the Bachman knee points are great. The shoestring point combination is pretty good. The channel balancing is good. The master dung points are great. And then you combine this with, you know, the appropriate treatment for the predominant external pathogenic factor, extremely successful. And I would say, you know, as the older the person is, the more treatments you'll probably need. But I would say most people are going to get pretty good results within the first 6 to 8 visits. And if they're a lot older and, you know, in really bad shape, especially if there's a lot of damp heat, that will take longer. But maybe a couple dozen treatments and they should start feeling a lot better. And liniments are really helpful. I make a liniment that's really good for arthritis pain that's worse with cold. And then I also have another liniment that's like really great for arthritis pain that's worse with heat, right? So interior cold, interior heat. I've got two liniments that are really good for those. If you're interested, I can talk to you more about those. And you have to move the blood and make sure that the blood is sufficiently getting generated and built. So you have to work on the earth quite a bit, right? Because this is often a damp condition or compounded by damp. So you have to really tonify the middle burner. You have to strengthen the stomach and spleen. You really have to get that working, those up to speed and resolve a lot of damp. So that's good. And move that blood, move that blood. All right, so that is the knee. Any questions in the 2 minutes we have remaining? No? Okay, very good. So I am going to either tonight or tomorrow afternoon, tomorrow evening at the latest, I'm going to put out, like, it might either be in the assignment section or discussion section, but I'll put it definitely in the announcement section, a little mini case study that I want you guys to like work through. It's going to be really easy, really easy. I might even put out 2, maybe choose one, but it's really easy. I'm just going to say, you've got this patient, they've got these signs and symptoms. What's your diagnosis? Or what assessment tools would you use, right? What would you do to assess this patient to help get a better sense of the diagnosis? What's your hypothesized diagnosis? and then what would be some treatments that you would do. It's going to be really simple. It won't take long, probably maybe a half an hour at the most for most of you. And then I'll definitely have that done by tomorrow night at the latest. And then that would be due like maybe Sunday night. And that would be part of like the discussions. I've realized like I haven't, you know, you probably noticed like I haven't put out like these discussion board assignments every week because I'm actually trying to, I'm feeling into you guys, and like people are like kind of weary. So between you and me and anybody else who's listening to this recording, I've been going a little bit easy on you, just to, you know, because I like, it's not worth it to me to like grind you guys down into a nub. You know, you guys got plenty of time after you graduate to really go over this material in situ. You know, I've set this up so that you can have something available to you either on your phone or your tablet or your whatever, or handwritten notes that you can refer to while you're treating somebody. You can look this up and go, oh, okay, these are the things that I write. Oh yeah, do this test. Oh right, try out. Oh yeah, look at this manual muscle test. Okay, I'll go and look at that video really quickly. It takes 3 minutes. Okay, got it, right. And they're also written out. I've like given them to you, like these muscle tests and the motor point locations, they're written out. So, you know, that's how I learned, and that's, you know, maybe how many of you will learn like in process, right? So you're welcome. Because I want to shorten your learning curve. I've tried to like just cull the landscape of what's available in terms of what's written and what's online, and chosen, okay, here's, based on my experience, you know, like a way of kind of going through the diagnostic process. And again, don't forget the spirit. You know, IDs, EDs, AE, upper kidney points. I mean, you know, I can't tell you how many times I've helped somebody on, like, as a 5L1 practitioner, you help their spirit, and a lot of their pain like lifts. It's like, you know, I told you, like, actually I didn't tell you this other class, teaching the 7th trimester people with the treatment skills class. Remember that, with like the cupping and all that? And I just happened to be like in the middle of a treatment with this patient, and I've known for like a long time. She was actually one of my first patients, and she comes like just occasionally when she needs a tune-up, and she threw out her back, and her like whole back seized up, and she was like in agony and like terrified. And so on the second visit, I was able to loosen things up enough on the first visit. So the second visit, I could do a little bit more. I did moving cupping, and I don't know why, I just happened to have my phone in the treatment room, which I never do. And I was just like, oh my God, like I got to take a video of this. So I just videotaped like about 5 minutes of this and edited out some. And we were actually going through this sort of like process of like her letting go of this old trauma that she realized that she was still holding into her back, holding on her back. And I was doing this like moving cupping with silicone cups while we were kind of going through this guided meditation, if you will, this process of like liberating, like getting in touch with, and then letting go of all this psycho-emotional pain that she had been holding in her body. And it was really powerful. I mean, she was just like weeping like crazy. And at the end of it, and like I just did like an upper kidney point, and a couple of spirit points for her on her CF, which is fire. And she got up, and it was just like, she looked like a different human being. She was standing taller. She was happy. She felt great. No pain. You know, she said the pain came back briefly, minorly the next day, but only because she had been like overdoing it that morning. Like she woke up the next morning, like, you know, singing and dancing. And so she went out and like worked out way too hard. And then, so that evening she had some pain again. And so, cause I saw her on a Thursday and then a Friday, didn't see her on the weekend. So Saturday it was like a little sore again. But so she texted me, like, we kind of like went through this guided meditation again, like for 5 minutes, 10 minutes. And then it eased up that night. And it's been like 95% better, maybe even more than that. Since then, I saw her yesterday, just like she wanted, just for the reassurance of like coming in. I did like some more, and then she was like bouncing around. She's sort of like a Tigger personality, and she was fine. She just wanted the reassurance of the, you know, the third treatment, but she was basically good. So long story short, like, don't forget to treat people on the spirit level. You know, like that is profoundly effective. All right. Well, I hope you have a great day. Try not to watch too much news. Don't, maybe take a few CBD gummies, before you go to bed. Just kidding. But take care of yourselves mentally, physically. As my old man used to say, don't let the turkeys get you down. Right. And I look forward to seeing you soon. And I'll have the little case study out by tomorrow night at the latest. All right. Ciao, ciao, everybody. Be good.
Thanks, time.
Thanks, time.
Bye, everybody.